This is just a quick PowerPoint to talk to you about tracheostomies. Well, and airway management. So if somebody is having trouble breathing, we need to do something to manage their airways. And that may be an oral airway, or it may be a nasopharyngeal, or it may be a tracheostomy tube or an endotracheal tube. Now, this video isn't going to talk about endotracheal tubes. That's in the fourth semester. So the oral airway, those are pictured here on the left of the screen here. The oral airway, also known as the oral pharyngeal airway, comes in a variety of sizes. It's placed whenever the patient's not able to maintain an open airway. So usually under anesthesia is when you see it, or some type of head injury. Um, the nurse is able to insert it. We do talk about them in the perioperative lectures. So if the patient's able to spit it out, they don't need the airway. You want to make sure you have the right size. They measure from the mouth to the tip of the ear to determine that they have the right size, and then they insert it. It looks like the letter C, and you insert it with the hook up, so you're hooking up to their upper palate, and as soon as you get past their tongue, you turn it around and insert it the rest of the way. There's I'm going to call it a bridge piece, but this is the part that sticks out of their mouth so that you can see they have the oral airway in place. And they're kept at the bedside for patients who may need them. Always know where they're at on your unit. The nasal pharyngeal airway, that's the one here on the right. Sometimes we call it a nasal trumpet, and that's usually inserted by respiratory therapy. It's lubricated. It's for somebody who needs better pulmonary hygiene and frequent suctioning. And that's primarily when we'll see it. And you want to make sure it's the right size. Lastly, we'll talk about tracheostomies. There's a variety of different kinds. A tracheotomy is the opening they make into the trachea, and the ostomy is the stoma or opening as a result of the tracheotomy. Its purpose is to bypass the upper airway obstruction. So for whatever reason, maybe they have an oral cancer or a neck cancer or throat cancer. Maybe there's I've had patients with an abscessed tooth in the back of their mouth that led to a cellulitis that then required emergency tracheostomy. Also, if they are having trouble getting them off of the ventilator, those are all reasons for having a tracheostomy. It bypasses the upper airway or any obstruction that's in there. It makes it easier to remove secretions. If somebody needs long-term ventilation because we're having trouble getting them off the ventilator, it helps with that. And it's safer long-term than an endotracheal tube. Always have a spare trach at the bedside. Neck ties or trach ties aren't changed for the first 24 hours. Sometimes they'll have, it's placed in surgery or at the bedside, and sometimes they'll have retention sutures in place. They would be sutured here, that faceplate to the neck opening, or sometimes the neck opening itself is sutured open. And the tube itself will require changing roughly every 29 days, or if there's a problem with the cuff. And that's usually the physician does the first change, and again, it's at the bedside. Or after that, respiratory therapy does that. We talk about all of the tubes, the obturator, and the inner cannula in the care of the trach. Thank you.